All right, so this will be kind of a more specific course-focused intervention, but my name is Charity Christensen. I came here to the U in 2008 working for the trauma surgery team here in the hospital, and then I transitioned over to the PA program in 2021. And then some of my trauma background also comes from work with the military.
Hi everyone, I'm Natasha Seliski. I'm an assistant professor here. I joined in 2023, had to think on that for a second. And I am the emergency medicine course director at the PA program. And then I'm hopefully in my last year of my PhD in population health sciences here at the U.
Thank you. So our objectives today are basically to tell you what we did with our trauma education and hopefully help you think about how you could potentially apply this to clinical learning in your own domains. So originally, our trauma education was 4 total hours in the emergency medicine course. There was a 2-hour lecture on kind of the initial care of the injured patient, or what we call the ABCDs of trauma, basically how to keep somebody alive long enough to figure out what's wrong with them. And then a second 2-hour lecture on various specific injuries that tend to show up on tests later in our students' careers. We realized that 4 hours of lecture on kind of a heavy topic and a topic that with our very primary care focused program can feel kind of abstract was not the way to go. So we evolved to a kind of a flipped classroom. We put our students in teams, we had them present on topics. And then unfortunately with that approach and the integration of AI, we ended up with a couple of slides that had some pretty bad and inaccurate, what I assume were AI hallucinations on them. So as we went back to the drawing board to figure out how to engage students in active learning and yet make sure that we were presenting accurate information in the classroom, we came up with this idea of doing a mock Morbidity and Mortality conference. Now, as we looked into the literature on this, there's a couple things people agree around. Active learning is great, but it takes a lot of time and some additional thought process to create that, and that when we do problem-based learning with students, it goes better if they have some expert facilitation. And so we kind of integrated those two ideas. It did take quite a bit of time. We made, I think, 10 different cases, and they each took 45 minutes to an hour to generate the content for each of the cases. So we broke our students into teams, we gave them chart review assignments. I'll show you in more detail what that looked like in a minute. And then we invited each of those teams to have their own private group discussion board where they as a group analyzed the documents that they were provided and kind of came up with a consensus of what was going on with the patient. And then we had them prepare summarized slides that were kind of the key learning points for their patient. On the faculty side, we actually prepared the kind of the testable content or the testable learning points that people needed to walk away from with this. And then we had kind of a hybrid presentation on our conference day where students would get up, they would present the case, and then we'd follow up with faculty kind of re-emphasizing the key clinical learning points. So this just shows what information we gave the students. I just picked group number 1 to show you. But you can see that we gave them not just a chart to review, but specific questions to answer about each different type of document. Now, not every chart had the same types of documents in them. One of the things we wanted to emphasize is that trauma care is across a spectrum, that it's not all just in the emergency department or in the hospital, but that sometimes the things that lead people to injuries start in the clinic or they start in urgent care and things like that. And so in a different case of ours, we also felt the need to talk about intimate partner violence as a source of injury. And we made sure that we had a note that kind of documented some yellow flags that didn't get followed up on to then show the effect of, hey, in this outpatient specialty care visit, there were warning signs that were missed, which then resulted in injury. This is a sample of the patient presentation the students came up with. I'm just going to roll through these next 3 slides to just show you what this ended up looking like. You can see this one had quite a lot of detail. Some of our slides had a little bit less detail to them because we didn't provide them a standardized format for these presentations. And then this is a sample of what kind of the faculty closing slide or 2 came out to look like, where again it was just very focused on key clinical learning points, but less about the patient. And that I'll hand over to Tasha for outcomes.
Okay, so as course directors in our PA program, we do get student feedback. And so in reviewing the qualitative feedback from the mock M&M, these are some of the examples we received. And overall, just to summarize some of this, we had student feedback that was quite positive in that they appreciated the real life scenarios. They appreciated the reinforcement of the clinical knowledge from content experts like Charity has had extensive experience in trauma in her military background. And then they also enjoyed looking at quality improvement pieces as well. And then some additional benefits that were reinforced by literature as a qualitative study out of Dartmouth on M&M conferences and the learning outcomes that individuals reported also once again included the reinforcement of medical knowledge and clinical skills through reflection, as well as acknowledgement that medical errors are just going to happen in clinical practice, and to have open discussion and dialogue on this to create a quality improvement system and identify systematic issues. And then finally, this also helps reflect real-world practice as well, and that these cases are actually based on real cases that Charity and I have been encountered, or on case studies as well, and that it also follows the patient from the EMS initial encounter through hospitalization to the outpatient follow-up. And then for implementation, of course, with any piece of curriculum implementation, this includes identifying where there's an appropriate curriculum placement. In this case, it was within emergency medicine, engaging and collaborating with key stakeholders, which Charity had this great idea for the mock M&M and approached me as the course director for emergency medicine in our PA program. And then developing cases with expert facilitator input. Again, had that input from Charity, who was our expert content creator in this case.
So we still have a little bit more data that we'll take a look at as far as how students perform on these topics as they move through the rest of their education and take some more standardized exams. We anticipate keeping this M&M format for next year, but with a couple of enhancements. So one is, I already mentioned that our case presentations, we didn't provide a standardized format, and that meant that we had kind of some variability in that quality. So that's something that we hope to enhance next year. And then the other item is we hope to add some kind of a peer review element to the actual M&M conference. It just, we've found that that keeps people a little bit more engaged when it's not their group's turn to present, if they're peer reviewing one another. And it also gives people real world feedback on kind of how their presentation went from somebody who doesn't know the patient. Can they actually understand the key points of what was happening with the patient based on the presentation? So that is all we have. Thank you all so much.